Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. Today I'm going to be talking about septic shock. I'm going to be continuing on with the shock lectures I've been doing. This is the last shock lecture I'll do for a while. So let's go ahead and get started. Hello, Clinic Review family. You know that this channel is part of the greater Clinic Review organization that was started by the GOAT himself, Mark Klimek, over 40 years ago. He is getting close to retirement, but he still has his online on-demand NCLEX review that you can get. It's over 21 hours of recorded content where he teaches you how to answer questions, how to grow in confidence, how to use the correct testing strategies. So this channel is really a supplement to that. So I do recommend the full online on-demand 21 plus hours of NCLEX review. I think you can sign up for how many months you want. I think a minimum of 2 months, I think. But you can sign up for the number of months that you want. We also have a streaming service and we have small group tutoring where you sign up for a monthly package for tutoring. Okay. So that's sort of the payment side of this organization. And we have sort of the free YouTube channel. So today I'm going to be talking about septic shock. Now, there are really 3 different types of shock. There's hypovolemic shock, low volume shock. It's in a class all by itself. Okay. Low volume shock. You got to give them fluids to correct that. The second type is cardiogenic shock. Cardiogenic shock is a result of a failing heart, and it's in a class by itself because there's no other type of cardiogenic shock except cardiogenic shock, right? It's in a class all by itself, just like there's no other hypovolemic shock other than low volume. The third type of shock is what we call distributive shock. Distributive shock is when there's a massive vasodilation throughout the entire body and the body can't maintain pressures. And so basically perfusion stops. When you can't maintain arterial pressures, perfusion just kind of stops. The blood just kind of stops where it's at. And so distributive shock is neurogenic shock, septic shock, and anaphylactic shock. I'm not planning to do a lecture on anaphylactic shock. Y'all, if the person's in anaphylactic shock, they need an EpiPen. That's what they need, okay? Epinephrine. Epinephrine is a vasoconstrictor. So we can also obviously give epinephrine for the other 2 types of distributive shock, neurogenic and septic. Okay, so epinephrine is, we usually give norepinephrine versus epinephrine, continuous IV drip. We can give those 2 because both neurogenic and septic shock is vasodilation. Neurogenic is a result of neurologic disruption from a spinal cord injury. So if you don't understand that, go and watch the neurogenic shock lecture. Septic shock is not spinal cord injury and it's not an allergic reaction. It's an infection. And sometimes when there's enough infection in the body and it actually gets into the bloodstream, so it's not like located to the lungs with pneumonia. It's not located in the urine with urinary tract infection. It's not isolated to a wound on the leg, right? It becomes system wide. When it goes system wide, we call that sepsis. So someone who develops sepsis is at risk for septic shock. Now, not every patient who with sepsis goes into septic shock, okay? But you have to understand that someone who's septic can go into septic shock. So that's what we're watching for. So sepsis is when you have a blood, the infection gets into the blood. Septic shock is when that blood infection causes this kind of massive reaction and vasodilation. And so when they have this kind of massive vasodilation, again, the body can't maintain pressures. And when the blood pressure, arterial pressure is not maintained, the patient ends up not perfusing anything. Okay. So we're going to talk about that. We're going to do questions and I'll kind of do the teaching as we go through the questions. But you've got to understand that all shocks, whether it's hypovolemic, cardiogenic, or distributive, all shock is low blood pressure that's low enough that it fails to perfuse the tissue. So it's poor tissue perfusion due to low pressures, right? So in all cases, we need to get pressures up. Now you would think, well, can we give fluids to everybody? Well, we give fluids to almost everybody, but we don't give fluids to cardiogenic shock. Even though it's low blood pressure, we don't because the heart is failing. It can't handle all those extra fluids. So then you go, okay, so we don't give fluids to cardiogenic shock. Are there any other differences? Do we give antibiotics to everybody? Well, why would we give antibiotics for shock? Well, we give antibiotics for shock in septic shock because it's an underlying infection and we need to address that, right? So you do need to understand that all shock is low blood pressure and poor tissue perfusion. All shock is that. but we don't treat them all exactly the same way. There's a lot of similarities, but they're not all exactly the same way, okay? All right, let's go ahead and see if I can help you understand this a little better. A nurse is explaining the pathophysiology of septic shock to a new grad. Which statements accurately describe the underlying mechanisms, okay, of septic shock caused by systemic inflammation leading to widespread vasodilation, leads to increased vascular permeability, increased cardiac output is always maintained, sepsis causes microthrombi formation leading to impaired tissue perfusion, hypotension is resistant to fluid resuscitation, primarily results from an excessive immune response to an infection. Okay, so we need to try to describe what septic shock is. So we read through them all. I don't know if any of them jumped out at you, so let's read them again. Septic shock is caused by systemic inflammation leading to widespread vasodilation. That's actually true. It is an infection, but this widespread infection leads to widespread inflammation. And somehow, I don't know if they even completely understand why the body responds to this widespread inflammation. Because you got to understand, inflammation, when there's inflammation somewhere, I'm not just talking about swelling, I'm talking about inflammation. It's an immune response, right? When you knock, or let's say you get a scratch on your hand and it turns all red and warm, that's an immune response. It's pulling more blood to that area. That's why it's warm and red, because it's pulling blood to that area to try to heal up that cut you just got on your hand. And so anytime there's inflammation, that's almost always a result of an immune response. And so you have this inflammation, kind of widespread inflammation, result of this immune response trying to fight off this blood infection. And for whatever reason, I don't know exactly, there's probably some biochemical reasoning for it. It leads to widespread vasodilation. So A is true. Septic shock leads to increased vascular permeability. That's actually true. And that's just probably something you just have to memorize, but that is actually true. And that has a lot to do with that inflammation as well. It's that inflammatory response that leads to vascular permeability. Septic shock has increased cardiac output is always maintained. So in septic shock, increased cardiac output is always maintained. That's false. When you have massive vasodilation, you actually decrease preload. Preload is the blood that's returning to the heart. So you have decreased preload, which decreases cardiac output. So C is not true. It's false. In septic shock, sepsis causes microthrombi formation leading to impaired tissue perfusion. That's true. So another thing about septic shock is that the sepsis leads to this microthrombi formation. So again, I don't know exactly why that is. I'm sure there's a reason for it. I just don't have that patho memorized. Septic shock, in septic shock, the hypotension is resistant to fluid resuscitation. That's true. And that's true for all distributive shocks. So when someone's in hypovolemic shock, we give them fluids. It takes care of the problem essentially, right? If you have low volume and we give you volume, that takes care of the problem. But when you have massive vasodilation, you got to give a lot of fluids to try to get the pressure up. And it is pretty resistant, particularly neurogenic and septic shock are pretty resistant to fluid resuscitation. With septic shock, there is primarily results from an excessive immune response to an infection. That is true. So there's going to be a question later where it talks about what are the complications of septic shock. And you need to understand that the complications of septic shock are a result of the pathophysiology of septic shock. So the physiology of septic shock leads to vasodilation, vascular permeability, microthrombi formation, resistant hypotension, and that's all part of the immune response. Okay, so you think, well, septic shock is low blood pressure. You're right, it is. We want to try to vasoconstrict. We want to give fluids. We want to give antibiotics to try to get this blood pressure up. But while we're trying to treat it, right, we're treating it, and we know it's probably going to at least take a couple days for the antibiotics to kick in, probably at least 48 hours for that antibiotic to really kick in and to start to see them reversing this. So we have to maintain it with vasopressors. Vasopressors are drugs that vasoconstrict, like norepinephrine. So we treat it with vasopressors and fluid and antibiotics. So it's going to take like 48 hours for it to really turn around. And while we're waiting for that to happen, we have to watch for increased vascular permeability and microthrombi formation. A patient with sepsis is receiving aggressive fluid resuscitation with normal saline, which finding would indicate that the treatment is effective. All right. So they have sepsis. Doesn't say they're in septic shock, but they do have sepsis. So we want something that says the fluid resuscitation is effective. And if we're doing fluid resuscitation, we only do fluid resuscitation with sepsis if their blood pressure is starting to fall. So they might not be in full blown septic shock yet, but we're seeing some symptoms that could be leading to it. And when you have, so you want to watch the blood pressure, you want to watch the heart rate, and you want to watch the urine output. These are the things that would tell me this patient is starting to perfuse their tissues. Because if they're vasoconstricting, their blood pressure is going to go up. If they're perfusing their tissues, they're going to have good urine output. And if their heart rate goes down, in other words, if they're not tachycardic, they're within normal limits for their heart rate, it tells me the body isn't needing to compensate for low blood pressure. Okay. All right. So what would indicate the treatment is effective? Increased urine output to 35 mils an hour. Well, normal urine output is 30 mils an hour. So that's good. So if it increased to 35, that tells me urine output is good. So they're perfusing their tissues. Systolic blood pressure is 85. Well, that's pretty low. That doesn't tell me the treatment is effective. Respiratory rate of 30, that's high. So that's not telling me the treatment is ineffective. Lactate level rises from 2.5 to 4.0. So one of the risks associated with septic shock is because you're not perfusing your tissues, they actually start to develop a metabolic acidosis from lactic acid being secreted from the lack of perfusion. And so their lactate levels start to go up. So normal lactate is less than 2 or less. That's what you want it to be. So if lactic levels rise, it tells you they're becoming more acidotic and they're actually going more into septic shock. They're like getting worse. So B and C don't tell me they're getting better. And D actually tells me they're getting worse. So the only one that tells me that they're getting better is increase. And it says increase. So I know it's higher than it was. So increase urine output. That's what tells me that they actually are getting better. A nurse is preparing to administer the first line treatment for septic shock, which interventions should be initiated immediately. So you should know what the first line treatments are, like what has to be done within the first hour when you suspect they're going into septic shock. Okay, so what do we have to do first line? Do we have to obtain blood cultures? Yes, because we need to know what's growing in there. Do we administer a 30 mil per kg IV fluid bolus? Yes, that goes in the first hour, and we usually want it to run in as quickly as we can get it in. So the way you calculate that aggressive fluid bolus is 30 mils per kilogram, so it can be quite a bit of fluids. Start norepinephrine. Do we start norepinephrine? Norepinephrine is a vasopressor, and it's actually only used if the fluid bolus doesn't work. So if we're thinking that first hour, norepinephrine is not first line. It's often used because we want to that's a vasopressor and we want to vasoconstrict, but we got to see if the fluid bolus works first. So no, we're not going to do C. Broad spectrum IV antibiotics, yes. We want to obtain the blood cultures and then start the IV antibiotics, but that can all be done in the first hour. And we don't wait for the blood cultures to be back to start the antibiotics. We do a broad spectrum until we find out what is actually growing in there. So that's good. Measure serum lactate levels. Yes, we need to do that in the first hour as well, because we need to monitor that lactate level to tell us, are they getting better or getting worse as far as acidosis is concerned. Apply ice packs. So no, we don't apply ice packs. You might go, but they have a fever, but we don't apply ice packs, not right at first anyway, for a fever. So those are the things you have to do in the first hour. A patient in septic shock is started on norepinephrine after fluids fail to improve blood pressure. So that's how we decide to start them on norepinephrine. What is the priority assessment? Urine output, peripheral pulses, blood pressure, blood glucose levels. So if fluids fail to improve blood pressure, and we're starting them on norepinephrine for blood pressure, what is the priority assessment, y'all? Blood pressure. So make sure you read the question, okay? So don't go, well, I don't know what am I supposed to be measuring with norepinephrine? Nobody taught me that. Y'all, it's in the question. We're giving it to improve blood pressure. So measure blood pressure, okay? Which laboratory result is most concerning in a patient with suspected septic shock? Laboratory result is most concerning. White blood cell count of 14,000. Well, that's expected when they're in septic shock. In fact, I would expect the white count to be much, much higher than that if they're in septic shock. So I say, well, no, that's not that concerning. Platelet count of 80,000. Y'all, platelet count is supposed to be 150 to 400,000. So 80 is pretty darn low. And there is, remember when we talked about microvascular coagulations, platelet count can contribute to that. So I am concerned about that. Creatinine level of 1.2, that's actually the high end of normal. So that's actually within normal limits, 0.6 to 1.2. And if it helps you, lithium levels are 0.6 to 1.2. Creatinine levels are 0.6 to 1.2. So if it helps you remember that. Blood glucose of 150, that's actually expected because the body reacts to this insult on the body by releasing stress hormones, and stress hormones increase blood glucose. So that's actually expected. So the only one that's really not expected at all is that B platelet count, which can start to drop pretty seriously when they are going into septic shock. Which action should the nurse perform first for a septic patient who has a temperature of 102.5, is anxious and restless, and has a mean arterial pressure of 55? Obtain blood cultures, administer 30 ml per kg bolus, start norepinephrine, or administer acetaminophen. All right, you don't have to answer this based on your best guess. This is not a best guess question. I've taught you prioritization strategies. If you haven't watched my prioritization videos, you need to go watch them. But this prioritization strategy is what we call Maslow. I call it modified Maslow. Mark calls it Maslow. Maslow tells us we have to address the objective problem first, the objective, the measurable problem. So let's see, what is the objective problem? Well, the objective problem is they have a temp of 102.5 and they have a map of 55. Anxious and restless. Anxious is sort of, it's not all that, it's actually not all that objective. It's sort of subjective, like I have to tell you I'm anxious. Restless is objective, but I don't know what to do about that. Like, I guess I could give some Ativan or something, but I'm not that crazy about giving Ativan to somebody who's going into sepsis. So I don't like that. So I'm looking at temp of 102.5 in the MAP. So obtaining blood cultures does not address the temp or the MAP. And by the way, the mean arterial pressure is supposed to be 65 or above. To maintain pressures, you can either do blood pressure or you can measure MAP. MAP is a better way of determining whether their blood pressure is adequate. And I talk about MAP in other shock videos, so I'm not going to talk about it again here. So MAP should be 65 or higher. So blood cultures does not address the temp or the MAP. Fluid bolus does address the MAP. So if we give fluid bolus, that should increase blood pressure. Norepinephrine infusion addresses the MAP, and acetaminophen addresses the temp. Okay, so we have two objective findings, and it seems like all of these things address, well, blood cultures is out. We're going to cross off blood cultures. And don't go, but we're supposed to get blood cultures first. No, that's not a rule. I told you there were 4 things you had to do in the first hour. I didn't tell you what order to do them in. Okay. Those are just 4 things you have to do in the first hour. This is what do you do first. So we're going to cross off A because it doesn't address the temp or the blood pressure. Now, when we have listen to me, when we have 2 objective findings and we have to choose between them, you are allowed to use ABCs to choose between them. You can only use ABCs. Listen, you can only use ABCs in a question like this. One patient, you have 2 objective problems and you need to prioritize between them. Then you can use ABCs, airway, breathing, circulation. Temp is not airway, breathing, circulation. Blood pressure is, that's circulation. So I'm going to prioritize treating the MAP over treating the temperature. So which ones address the blood pressure? Well, B and C both address blood pressure. So what should I do first? Remember, I told you norepinephrine. What do we do before we do norepinephrine? We have to give them a bolus first. We got to see if that works. So what should I do first, y'all? I've got to administer the fluids first. And look, you may say, hey, my teacher taught me something different. That's fine. Maybe your teacher was teaching you like hospital policy. Maybe your hospital has a policy of always doing blood cultures first. I don't know. But there has to be an objectively right answer on the NCLEX. Otherwise, it's not a good question. It's just someone's opinion. There can be no opinion questions on the NCLEX, which means there has to be a rule. And the rule is when you have one patient with multiple symptoms in the question, they say, what are you going to do first? You always address the objective problem first. I have an entire video on this, so I'm not going to spend a lot of time on it now. A nurse is monitoring a patient with sepsis, which finding requires immediate intervention. So the patient has sepsis. All right, here's another prioritization strategy. When you have one patient and all the symptoms are in the answers, and it says, what are you most concerned about? But Sharon, it doesn't say what are you most concerned about. All right, listen. What requires immediate intervention? The thing we're most concerned about. Okay, so it means the same thing. Immediate intervention. What are you most concerned about? What are you going to call the doctor about? What do you call the doctor about? Well, the thing I'm most concerned about. You're right. So all those things mean the same thing. So we have to immediately intervene with the unexpected finding. So you have to say, is this temperature expected or unexpected with sepsis? Do you expect someone with sepsis to have a temp of 100.5? Yes. I mean, they got a bloodborne infection, so their temp would be up. Yeah, that's expected. Would you expect someone with sepsis to have a white count of 22,000? Yes. That's why they're septic, because their white count has gone up so high. Would you expect someone with sepsis to have a heart rate of 108? Well, I might. I mean, the body's trying to work hard. I mean, I may be a little bit concerned about, if anything, I might be a little bit concerned about that. 108, maybe. It's outside normal limits. So let's say maybe I'm concerned about that. Would you expect someone with sepsis to have a lactate level of 4.5? What did I tell you the normal lactate level is? Less than 2. So we've got two things that are outside normal limits. One of them is really outside normal limits. The heart rate tells me there's a reason the heart rate is up. Why? Well, it could be because they're stressed. It could be because their blood pressure is dropping. I don't know. It's not a real specific indication of what's going on. So it could be. Why does the lactate level go up? The lactate level goes up because they're becoming acidotic. Are you more concerned about the heart rate that might be up for a bad reason, or the lactate level that is always up for a bad reason? I am most concerned about the lactate level that is always up because they're acidotic. That's the only reason that lactate level is going to go up with sepsis, y'all. It's because they're becoming acidotic. That's a big problem. A patient with sepsis is at risk for developing complications. Which conditions should the nurse monitor for? Acute respiratory distress, ARDS, disseminated intravascular coagulation, DIC, myocardial infarction, acute kidney injury, neurogenic shock, or multi-organ dysfunction syndrome. All right, do you remember the first question when we talked about pathophysiology? And we talked about how sepsis increases vascular permeability? Well, when that happens, they can get fluid in their lungs, which is ARDS. ARDS is when you have increased vascular permeability and you get all this fluid in your lungs. So yes, that's a complication we got to monitor for. Disseminated intravascular coagulation. Remember we talked about microvascular clotting? That's DIC. So I got to watch for B. Myocardial infarction. That's not considered a risk factor related to sepsis. Acute kidney injury. Well, septic shock, developing sepsis, or sepsis. So if they go into shock, they're going to have poor tissue perfusion and their urine output goes down. So they could have acute kidney injury. So yes, I got to watch for that. Neurogenic shock, sepsis does not lead to neurogenic shock. It leads to septic shock. It does not lead to neurogenic shock. And multi-organ dysfunction syndrome. Any shock can lead to MODS. So MODS is when you have such poor tissue perfusion that all your organs start to fail. Like your kidneys start to fail, your liver starts to fail, everything starts to fail. Okay. That's like worst case scenario. So those are the things that I have to monitor for. A nurse is teaching a patient about preventing sepsis. Which statement indicates understanding? I should take antibiotics for any fever. No, that's not a good idea. I will get my flu and pneumonia vaccines. Preventing sepsis. Well, if you don't get the flu or the pneumonia, that could prevent you from becoming septic. So if you don't know this, particularly in older adults, pneumonia is a big reason. The flu leads to pneumonia. Pneumonia often leads to sepsis, particularly in older adults. I will only go to the hospital if I have severe symptoms. That's not going to prevent sepsis. I should avoid drinking water when I have a fever. That has nothing to do with anything. So if we're talking about prevention, we want to prevent them from getting sick in the first place. So let's do the flu and pneumonia vaccines. Which laboratory findings suggest sepsis progressing to septic shock? So remember I said sepsis can lead to septic shock. So what's going to tell us that? Elevated lactate. Well, that means they're becoming acidotic. So yes. Elevated procalcitonin. So the procalcitonin is an indication of system-wide inflammation. Do you remember back in that very first question where we talked about that system-wide inflammation leads to increased vascular permeability, which can lead to ARDS, adult respiratory distress syndrome. See how these things go together? So procalcitonin actually is something that goes up as they start to have this system-wide inflammation. Leukocytosis is elevated white count. So yes, you need to know your vocabulary, y'all. Leukopenia is low white count. Leukocytosis is elevated white count. Increased platelet count. Actually, I'd expect it to go down. Metabolic acidosis, yes. When they have poor tissue perfusion, they can release lactic acid, which leads to metabolic acidosis. Hyperglycemia, actually, yes. The body responds to stress on the body by increasing stress hormones, which cause hyperglycemia. So actually, all of these things, except increased platelet count, are laboratory findings that suggest sepsis is progressing to septic shock. So that's a lot. You may need to watch this video again to really kind of start to understand it. The purpose of this channel is really to prepare you for NCLEX. It's really not to do massive, long lectures on things. This channel is really geared more towards helping you better understand something you've already learned about. Like maybe you learned about shocks in class, but you just need a refresher. Or maybe you're getting ready to do the NCLEX and you're like, I just don't get the different shocks. Let me review that. Right. So this is not intended to be your first introduction to septic shock. Okay. So you should have already learned about it and now you're just kind of refreshing. So I know it's a lot, but if you've already had your lectures already, then hopefully this is enough to help you understand it. So I thank you for being a part of the Clinic Review family, and I hope you have a great rest of your day.